In lymphoid neoplasm, okay, so now we will, I'll make your life a little easy because these are the topics: lung cancer, lymphoid neoplasm, and leukemia. These are the three topics which would have, which would be new topics for the cumulative final. What does that mean? That means that these topics, there'll be more questions out of these topics. I have not yet decided how many questions will be there, but there will be more questions out of these topics in your cumulative final. Okay? So, in lymphoid neoplasm, please go over the general, introduction. That is, what's a lymphoid tissue, all right, and basically how what happens, in what cells the lymphoid neoplasm occurs. Usually occurs in T cells and B cells. Okay. Then I have included some definitions over here. What is the difference between leukemia and lymphoma? Leukemia is actually present in what you may call, it's actually present in the bone marrow. Basically it requires the involvement of bone marrow, and that happens usually, but it's not true all the times. And it also requires the involvement of peripheral blood. Okay. Lymphoma is used for the proliferations that arise as discrete tissue masses. Now, these lymphomas can be classified, right? Now, there are many different classifications that are present, and on the basis of those different classifications, the lymphomas can be classified differently. But we will stick to WHO classification, right? Now, the broadly, lymphoma is classified into two categories. First is Hodgkin's lymphoma, and the second is non-Hodgkin's lymphoma. Okay. Now, Hodgkin's lymphoma and non-Hodgkin's lymphoma, the main characteristic difference between these two is the presence of Reed-Sternberg cells in Hodgkin's lymphoma. Okay. So what is it? It's presence of Reed-Sternberg cells in Hodgkin's lymphoma. This is a brief introduction overview of what Hodgkin's lymphoma is. It was, discovered by Thomas Hodgkin, who basically describes 7 cases of this disease in 1832. Now, epidemiology and etiology. Go over the epidemiology and etiology of Hodgkin's lymphoma. It's pretty straightforward. Studies have suggested that Hodgkin's lymphoma in patients, Epstein-Barr virus, EBV, is associated with the occurrence of Hodgkin's lymphoma. Okay. Now, you remember I mentioned Reed-Sternberg cells. Reed-Sternberg cells are nothing but they are large bilobed multinuclear cells that look like owl eyes. Okay, if you have looked at the owls, their eyes are very circular, right, very round. So that's how the Reed-Sternberg cells look like. Okay. Now, immunosuppression is also related to Hodgkin's lymphoma. So meaning patients who are actually recipients of solid organ transplant, or patients who have a disease that has led to immunosuppression are at a higher risk of developing Hodgkin's lymphoma. Okay. Okay, now when we go to the pathophysiology here. So when we go to the pathophysiology, EBV, Epstein-Barr virus, okay, this is important. Then JAK-STAT signaling pathway. So any alterations in JAK-STAT signaling pathway may also cause Hodgkin's lymphoma. Now, on the basis, you remember I said that, the classification that we talk about, or the classification that we follow, is WHO classification. Okay, and WHO has classified Hodgkin's lymphoma into two: classical Hodgkin lymphoma that constitute about 95% of the cases. Okay, it is characterized based on the presence of Reed-Sternberg cells. Okay, now it is of these types: nodular sclerosis. Okay, it is further subdivided into nodular sclerosis, mixed cellularity, lymphocyte depleted, and lymphocyte rich classical Hodgkin's lymphoma. Okay. Now so two types, right? Up till now we talked about the classical Hodgkin's lymphoma that is further subclassified into nodular sclerosis, mixed cellularity, lymphocyte depleted, and lymphocyte rich. Then the second type is nodular lymphocyte predominant Hodgkin's lymphoma. Nodular lymphocyte predominant Hodgkin lymphoma. Okay, it is more indolent in nature. Indolent meaning more passive. It's not aggressive. The proliferation is very slow. Okay, so because it is indolent, that's why the prognosis is better. Now, this point that we are going to discuss now, typical immunophytotype. So we do immunophytotyping in order to find out the markers. Now, for classical Hodgkin lymphoma, the typical immunophytotypes or the markers are CD. So markers, these CD cells are cluster of differentiation cells. And this type of nomenclature, CD, you see this number, right? CD15, CD30, right? This classification was started to classify different types of white blood cells that have expression of both the alleles of a monoclonal antibody. Okay, so let me repeat it. This type of classification was started to classify white blood cells that have two alleles of a monoclonal antibody. Okay, so that's why it is called as cluster of differentiation, CD. Now let's say if it's CD15, that means this number represents the antibody that is present on these cells. Okay. Now this type of classification can be seen to classify other types of blood cells as well. Now, in classical Hodgkin lymphoma, the markers are CD50, the positive markers, the presence. Positive meaning present, right? So the positive markers are CD15, 30, PAX5. Okay, so PAX5 is weak, and the negative markers that are not present are CD3, 20, 45, and 79A. Okay. Now, nodular lymphocyte predominant Hodgkin lymphoma, or NLPHL, the immunophytes are reverse of that of classical Hodgkin lymphoma. So in classical Hodgkin lymphoma, CD15 plus was there. In NLPHL, CD15 minus is there. In classical Hodgkin lymphoma, CD20 minus was there, marker, right? In NLPHL, CD20 plus is the marker. Okay, so just remember that. So you have to remember only one, markers of one, and then the markers of other are exactly opposite. Okay. The markers that are not present in NLPHL, these are the ones: PAX5, and CD79A. Rest everything is there, right? 15, 20, 30, 45. Okay, now non-Hodgkin lymphoma, just read about it. It's pretty self-explanatory. Now, out of the two, right, Hodgkin lymphoma and non-Hodgkin lymphoma has better survival rate, right, of a 5-year survival rate of about 85%. Non-Hodgkin lymphoma, the survival rate has increased over the past 48 years, and the mortality has declined. Okay. Okay, again, immunosuppression. So, an increased incidence of non-Hodgkin lymphoma is seen in many congenital and acquired immunodeficiency states. This is important for you to know. The patients that are suffering from Wiskott-Eldridge's syndrome, ataxia, telangiectasia, AIDS, or the patients who are receiving pharmacologic immunosuppression in case of solid organ transplant, those patients are predisposed to the development of non-Hodgkin's lymphoma. Patients that have autoimmune diseases like Hashimoto's, Soren's syndrome, they are associated with mucosa-associated lymphoid tissue, the inflammation of MALT, right? These all conditions are associated with lymphoid malignancies. Okay, autoimmune diseases like systemic lupus, rheumatoid arthritis, they are also associated with NHL. Now, the EBV is associated with African endemic Burkitt lymphoma. Okay. Can anyone tell me what is Burkitt lymphoma? What type of translocation mutation happens in there?
T814.
T814.
8.
Okay, good. Then there is another virus that is, involved in the occurrence of non-Hodgkin's lymphoma, Kaposi sarcoma virus. It's also called as Kaposi sarcoma associated herpes virus. So that's why the abbreviation is KSHV. Okay. Patients who are, contracted with chronic H. pylori infection. H. pylori is gram-negative bacteria that may lead to gastritis. It is associated with MALT lymphoma, right? Hep C is also associated with, certain types of lymphomas. Molecular abnormalities are important. So the most common chromosomal translocations T814, that involves the mutations in c-MYC in Burkitt lymphoma. T1418, that involves the mutations in PCL2. Excuse me. They are associated with the cases of follicular B-cell lymphomas. Okay, T1114, these are associated with BCL1 mutations, and they can be found in about 70% of MALT. I'm sorry, not MALT, but mantle cell lymphoma. Okay. Now, another mutation in B-cell lymphoma associated oncogene, that is BCL6, that's found in diffuse large B-cell lymphomas. Okay, mutations in P53 have been, now P53 mutations are found in lymphomas, but they are not consistently present in all the lymphoma patients. Okay?
Dr. Kumar.
Yes.
What about the IRF4 rearrangement? Is it in large B-cell lymphoma?
What is that?
IRF4 rearrangement.
IRF4, I will have to look into it. Is it there in the notes?
I don't know. I just remember it from my memories, like large B-cell lymphoma.
Okay. I'll have to look into it. I will get back to you. Is that okay?
Yes, thank you.
Okay, great. Okay. Now, so clinical presentation, just go over the symptoms that are there. Okay, I will not test you on the details of clinical presentation because I'm not a clinical pharmacist. Okay, so but just go over the important clinical symptoms. Okay, so here diffuse large B-cell lymphoma, it's these type of lymphomas, they are actually treated with a very unique therapy. Okay, so up till now, what we have seen the drugs that would actually target the drugs that would target the markers, right? So these are targeted drug therapy. Up till now, we have also talked about conventional chemotherapy. Now, this type diffused large B-cell lymphoma are treated with a very new type of therapy that is in development. Actually, it's in clinics now. It's called as CAR T-cell therapy. So let me write it here. CAR therapy. Okay, so what happens in this type of therapy is T cells are harvested and from the patient, from the patient's peripheral blood, the T cells are harvested and then they are genetically modified ex vivo. Ex vivo meaning outside the system or the body by retroviral transduction. Okay. And this will express a chimeric antigen receptor. So that's why it is called as CAR, C-A-R, chimeric antigen receptor. Okay, it comprises a murine anti-CD19 single chain variable fragment that is linked to CD28 and CD3 co-stimulatory domains. And then what will happen? That the cells, these or genetically modified T cells are re-injected to the patient. Okay, so initially what we did, we removed the T cells of the patient from peripheral blood, genetically modified the T cells, and then re-injected the T cells. Now these T cells will recognize the CD19 expressing target cells. Okay, that means, and then what it will do, it will lead to T cell activation, proliferation, and when the T cells are activated and proliferated, these are the cells that will recognize that specific, target and will kill those, malignant cells or transformed cells. Okay. So we will discuss, this is very cool. That's why I thought that I should mention it out here. We will discuss this type of therapy and many such therapies when we study the onco pharmacology. Okay, now moving on to lymphoblastic lymphoma. It's a rare variant of non-Hodgkin lymphoma, male predominance, frequently associated with T714 mutation. Okay, follicular lymphoma, we already discussed about it. it is associated with T1418 mutations. Okay, translocation mutation. Please go over these notes. If you have any questions, feel free to reach out to me. Okay, let's move on to leukemias. Okay, so leukemias, if you want to understand the leukemias, first we should know these hematopoiesis. If you want to refer to hematopoiesis, please refer to the slides. There is a picture of hematopoiesis. So basically what happens, the hematopoiesis, it starts, or hematopoiesis meaning, poiesis meaning generation, right? Heme is related to blood. So blood cell generation, right? That is hematopoiesis. Now, it all starts with a stem cell. A stem cell that is pluripotent or multipotent. Pluripotent or multipotent, as we discussed in one of our earlier lectures, meaning the stem cell that has a potential to acquire multiple functions. Meaning it could become a heart cell or cardiac cell, it could become a kidney cell, it could become a blood cell, it could become T cell, B cell, so those type of cells, that property is called as pluripotency or multipotent. Okay, so once the immature stem cells, then they get matured into blast cells, or they become blast cells, all right, and then the blast cells will basically have a defined function. Okay, the blast cells can can become platelet cells, WBCs, eosinophils, basophils, neutrophils, red blood cells, all those different types of blood cells. Okay, so this is in nutshell the hematopoiesis. Now, now leukemias basically happen any mutation in blast cell or any mutation in a developed blast cell may cause leukemia. Okay, so here we are talking about generally what leukemias are. There are 4 types of leukemias. They're divided into 2 acute subtypes and 2 chronic subtypes, right? So acute lymphoplastic or lymphocytic leukemia, ALL, acute myeloid or myelogenous leukemia. Then same thing goes with the chronic types, right? Chronic lymphocytic leukemia and chronic myelogenous or myeloid leukemia. Okay, it starts with the undifferentiated immature cells that proliferate autonomously. So basically, the difference between the acute leukemias and chronic leukemias is both of them happen in the cells that both of them happen in the undifferentiated immature cells that proliferate. I'm sorry. So let me repeat it again. So the difference between chronic and acute leukemias is that acute leukemia starts in the undifferentiated immature cells. The proliferation is autonomous. Okay, chronic leukemias, the proliferation is autonomous here as well, but the cells are more differentiated and matured. Okay. Now, acute leukemias, if they are left untreated, then they are fatal within weeks to months. Go through the epidemiology. It's important. The epidemiology and etiology is very important here. So let me tell you what is important. So um, among adults, acute and chronic leukemias, they occur at equal rates. AML accounts for most cases of acute leukemia in adults and occurs with increasing frequency in elderly patients. However, ALL starts in the kids, the kids ranging from 1 to 4 years. Okay. Now, acute leukemia is more common in males than females. It is okay. Yeah, United States, the acute leukemia is more common among whites as compared to blacks, American Indians, and Hispanic ethnicities. So please go through these points. These points are important because that will clarify which type of leukemia happens, what age group. Okay, this is important with respect to leukemias. Now, risk factors, in children, ALL risk factors are exposure to ionizing radiations, toxic chemicals, herbicides, pesticides, maternal use of contraceptives, for example, diethylstilbestrol or cigarettes, paternal use of mind-altering, drugs or cognition-altering drugs like amphetamines, diet pills, diagnostic radiographs, alcohol consumption, coffee, cola consumption, or chemicals before and during pregnancy. Now, benzene exposure, radiation exposure is also associated with ALL and AML. Now here we have discussed the pathophysiology of ALL. Now, if you want to understand the pathophysiology of leukemias, right, you should understand the hematopoiesis, and we've already discussed briefly what hematopoiesis is. This is important. Leukemia may develop at any stage and within any cell line. Okay, two features are common to both AML and ALL. First is they arise from single leukemic cell. That means that all it takes is the mutation in one, cell. Okay, so they will arise in single leukemic cell, and then the proliferation will happen, and which will replace the, the transformed cells will then replace the normal cells. And there is a failure to maintain a relative balance between proliferation and differentiation. Okay. Now, AML likely arises from a defect in pluripotent stem cells or a more committed myeloid precursor, resulting in partial differentiation and proliferation of immature precursors. Now, there was another point. Yeah. So in older patients, the trilineage leukemia occurs. Trilineage leukemia meaning in all the three blood cells. Okay. The trilineage leukemia occurs in all the three blood cells, RBCs, WBCs. Okay. Now, platelets. Now, in younger patients, a more differentiated progenitor becomes malignant, allowing a maturation of some granulocytic and erythroid population. Okay, so these 2 points are important here. Again, for leukemia classification, we follow WHO classification. Okay. Okay. Now, unique translocations that are more or the one. Okay, so the translocations that are associated with leukemia, the unique translocation first is ETV6 RunX1. It was formerly known as TEL-AML1. So in this translocation, what happens is, it's between the chromosome 12 and 21. Okay. P13Q22 that you are seeing over here, that means the arms of chromosomes. So P13 arm of chromosome 12 and P22 a Q22 arm of chromosome 21. So when these fuse together, it leads to a chromosomal translocation, makes a fusion gene that is called as ETV6 RunX1. Okay. Now, this translocation, it appears to endo the pre-leukemia cell with altered or self-renewal and survival properties. Okay. Then the second one is, it occurs in adult ALL. T922 translocation. We have been hearing about this translocation since the start of oncology. It's called as Philadelphia chromosome positive, pH positive. Okay. Then we also see Notch1, mutations in Notch1. So what is Notch1? It is, so basically Notch1 determines the fate of the cell. Okay, so it determines that what function a cell would perform. So that is, the function of the cell is determined by a protein called as Notch1. Okay, so it may have a role in, not may, it plays a role in cell growth and division, that is proliferation, differentiation, and it also plays a role in self-destruction or apoptosis. So this protein, meaning it has diverse function, that the gene is considered both as it can be considered as an oncogene or a tumor suppressor gene. Okay, so mutations in this gene may cause, leukemias. Okay, now acute promyelocytic leukemia, the translocation is between chromosome 15 and 17, so it's called as T15-17 translocation. Now there are some molecular tests that are used to identify PML. Okay. And those tests are, if you want to see the acute promyelocytic leukemia, then it should be the presence of retinoic acid, the mutations in RAR alpha gene. Okay, RAR alpha, retinoic acid receptor alpha, is also a nuclear receptor. Okay, and then the fusion of AML1 ETO can also be seen. That is also called as translocation of 821. So AML1 and ETO 821. Okay, so it's the translocation between chromosome 8 and 21. So if you remember this ETO 821, and then there are translocations between CBFB, core binding factor beta, and myosin heavy chain 11 fusion, right? That may also cause AMLs. Okay. Now, if we go to the classification, this is the classification of WHO classification of leukemias, right? So acute AML is with recurrent genetic abnormalities, meaning AML1 ETO. Okay, then AML with abnormal bone marrow eosinophils and inversion of 16 in P13Q22. These are all the translocations that we should remember. Okay. Now then there is this we have already discussed, but AML with 11Q23 MLL abnormalities. MLL encodes a histone methyltransferase, that is critical for maintaining gene expression during embryonic development and hematopoiesis. So MLL gene translocation generate a chimeric MLL fusion protein that will directly bind to DNA and positively regulate the gene transcription. It results in the aberrant expression of downstream MLL targets, including HOX gene, and that may lead to leukemic transformation. Okay? Then, these are simple classifications, multilineage dysplasias, therapy related, there are certain drugs when cancer patients, they are treated with certain drugs, then the risk of developing other cancers or secondary cancers in those patients increases. And usually alkylating agents, for example, cyclophosphamide is a drug that is classified as alkylating agent, right? Can be, when patients are on that drug, they are at a risk of, developing secondary cancers, okay, or secondary leukemias. Radiation related, if patients are on radiation, therapy, then they are also at this risk. Then topo 2 inhibitors. The example is epipodophylotoxins. So this is a type of drugs. The member of this class is etoposide. Okay, etoposide or tenofovir. These are the two drugs that are topo 2 inhibitors. And if the patient is being treated on these drugs, with these drugs, then the patient may be susceptible to secondary cancers or secondary AML. Now there are other drugs as well, but I thought that these two are more important. So topo 2 enzyme, has anyone heard of topo 2?
Nope.
Okay, so where did you guys go? Okay, so topo 2. So what happens? DNA at the time of replication, right? What happens is DNA replication fork is made. Okay. Now, so basically, what happens? The replication, when the replication is happening, the unwinding of the strand is happening, right? Yes. Okay. So when the unwinding of the strand is happening, this is how it looks like. It's a replication fork. One, strand would be, complementary strand would be, made on this end of the, or this side of the fork, and the other one would be made at this side of the fork. Now, because of this, it's imagine it like a Y, right? So because of which the strand, that is the DNA strand that is not open yet, is undergoing a lot of stress and strain. Because imagine it like a rope, okay? If you open the rope, what will happen? You will see intertwining or entanglement of the rope that is in the part that is not open. Okay, so so that generates a positive stress in the DNA strand, because of which what may happen, if the proper measures are not taken, then what will happen? The DNA strand will break, the replication will stop, and thus DNA will die. Okay, so physiologically, what happens when a replication happens? There are certain enzymes, topo 1 and topo 2 enzyme, topoisomerases. These enzymes, what they do, they will produce a nick in a cut in the intertwined strand portion of the DNA strand, and then it will release that stress and religate the strand. Religate meaning rejoin the strand. Okay, so that is the function of topoisomerases. Now, this is in normal physiology. Now, this function has been identified by cancer cells, and they exploit it to their benefit. So what do? they will basically, if there is a faulty DNA, right, they will repair the DNA, and by using topo 2 topo 1 enzymes, and that is one of the reasons why the cancer cells don't die. Okay, so that's why when scientists, they found out that this is what is happening, they came up with the inhibitor drugs that can inhibit these enzymes. Did it make it clear?
Sorry, could you repeat what you said cancer drugs do with the topoisomerase? Or what does cancer cells do? Yeah.
So cancer cells, what do? Is they have exploited this phenomenon. Okay, so if there is a faulty DNA, okay, if that DNA is undergoing, if there is a mutant DNA, let's say, and that mutant DNA is undergoing the replication, then they will hyperactivate the topoisomerases. So to make sure that the DNA replicates, so that we have more and more DNA and more mutant DNA, and that will work in favor of cancer cells. So when the topoisomerase inhibitors, what do? They will inhibit this enzyme. So when they inhibit this enzyme at the time of the replication, the there would be positive stress caused in the DNA strand, because of which it will lead to DNA strand break. And when the DNA strand break is when it takes place, then what will happen? The DNA will die. Okay, when the DNA dies, the cell will not be able to replicate.
Dr. Kumar, wouldn't that inhibitor affect all cells? Because topoisomerase plays a role in DNA replication of all cells.
Very good. So it will, affect all the cells. That's why these drugs are called as conventional chemotherapeutics, right? And that's why these drugs have pronounced side effects, because they are killing healthy cells as well as they are killing the cancer cells. They don't know how to identify between a cancer cell and a healthy cell. Okay, so that's why in cancer we are moving towards targeted therapy or CAR T therapy, so that the drug is smart enough to identify the cancer cells on the basis of the markers. Okay. All right. So moving on, clinical presentation, just here. So the diagnostic test is bone marrow biopsy and aspiration, okay, which is basically and immunophenotyping. So cytogenetics is also done, immunophenotyping is done. So in immunophenotyping, FMS like tyrosine kinase 3 mutations are happening. Now, FMS like tyrosine kinase 3 or FLT3, I in my PhD, I came up with, I discovered a drug that could reverse the multi-drug resistance. Actually, I discovered two drugs that could reverse the multi-drug resistance. One of the drug worked on FMS, FLT3, associated AML. Okay, so basically what happens in FLT3 associated AML is mutant FLT3, what it will do. So FLT3 is present downstream of tyrosine kinase receptors. Mutations in FLT3, what will the mutations do? They will constitutively activate the tyrosine kinase receptors that will lead to constant or increase growth and proliferation, cell growth and proliferation. Okay. Then comes a nucleophosphine, phosmin 1. So nucleophosmin, it is the gene, this encodes a protein that is involved in processes, several cellular processes, including centrosome duplication, protein chaperoning, and cell proliferation. Okay, so encoded protein, it shuttles between the nucleolus, nucleus, and cytoplasm, chaperones ribosomal proteins, and core histones from nucleus to cytoplasm, and it is also known to sequester a tumor suppressor ARF in the nucleolus, and by doing so, it protects the ARF against degradation. Mutation in this gene is actually associated with acute myeloid leukemia. Then CCAT, enhancer binding protein alpha, CEBPA. The mutations are also, indicative of AML. Then lumbar puncture is performed to determine if there are any blasts in CNS. Chest radiograph is done to screen for mediastinal mass. And now this brings us to ALL, acute lymphoblastic leukemia. So remember these mutations, T1221. There happens hyperdiploidy. So favorable outcomes are associated with 3 copies of 4 and 10 chromosomes. Hyperdiploidy, meaning 51 to 65 chromosomes are present, and ETV6 and RUNX1 cryptic translocations. Okay, so please go over these translocation mutations, and if you have any specific questions, let me know. If there is no description is there for a mutation, I will not test you on the description. Okay, as long as you remember that this type of mutation happens in this type of in a particular leukemia, you should be fine. Okay, acute myeloid leukemia. These are the mutations here. Please, pay focus on these mutations here. Okay, and then focus on the molecular testing as well. Then chronic leukemias, they are divided into CML, CLL, hairy cell leukemia, pro-lymphocytic leukemia. Okay. Go over the chronic myeloid leukemia. Chronic myeloid leukemia, the pathophysiology depends on the presence of Philadelphia chromosome. Okay, so go over it. I have included it in the text, the description of it. And then it also, okay, here in clinical presentation, I have included main points there. Okay, so go over these main points. Okay, then chronic lymphocytic leukemia. Here, CD5 plus B lymphocytes. Okay, these are important. Then, Bruton's tyrosine kinase is important. Okay, PI3K. So go over these. All right. Now, somatic mutations are also important. For example, TP53, ATM, all these. As long as you know the genes, you should be fine. Okay. I will not test. I will not test you on the function of these genes. Okay. And then go over the clinical presentation. Myelodysplastic syndrome. Just go over the text. Polycythemia vera. As long as you remember that it involves, or point mutation in JAK2 is associated with polycythemia vera, you should be fine. Primary myelofibrosis is the underlying mutations are JAK-STAT, mutations in JAK-STAT signaling pathway. Okay, and then here I have included a picture of JAK-STAT signaling pathway as well. Okay, and with this, I would like to end the lecture here.
I have a question on just part of your handout on the beginning. You have the risk factors. What is it? It said in pediatric ALL. So I think this is page 3. Page 3. It says in pediatric ALL, these factors are inconsistently linked. So I just wanted to make sure that you meant, yeah, the third point. So inconsistently linked means it's not always the case, but sometimes.
Correct. So these are the environmental factors that are so there are several environmental factors that may be associated with ALL, but they're not inconsistently linked, meaning not all the times you would see these factors. You would see that the ALL is happening because of these factors in the patients, right? So that's why for ALLs or for leukemias, you rely on the risk factors, the environmental factors, the immunophenotyping, and cytogenetic factors. Okay.
So then for like high birth weight, would that be more consistent when you say that there's a growing body of evidence?
So growing body of evidence meaning, so high birth weight or low birth weight has more chances. Those patients have more chances of contracting, certain types of leukemias. Okay. Now, it's not that always. It's not for certain, right? So if a baby is born with high weight, it doesn't mean that baby will have a leukemia. It means that baby may be susceptible to get leukemia.
Thank you, Dr. Kumar.
Yeah. So I don't know how to. Where did my window go? Oh, it's right here. Okay. So, do you want to quickly discuss the quiz, or you guys are fine?
We have a quiz